that the palliative and supportive care will get larger over time until we get to end of life care. And that can be exclusively focused on palliative care. And after the child passes away, we have bereavement care, which can also be provided to the family. And sometimes for neonates, all of this happens very quickly, right? So sometimes when they are diagnosed, when they're born, we're already into the end of life care phase for very premature neonates because they don't have a lot of time to live, unfortunately, which has its challenges, but we can help them. Overall, our goals in pediatric palliative care is to live and enjoy life, have the child have the best quality of life, have connections to their family and friends, ideally if they can be at home or in a safe place. Now, sometimes a safe place is the hospital. Parents may feel more comfortable with a premature baby staying in the hospital, but we do want the mother and the baby especially to be together. And, you know, for older children, we want the parents and the child to be all together as a family. And for older children, we think about all the activities children like playing and songs and arts and crafts. And those are the things that are important that we want to enable children to do. When we think about which children need palliative care, we can think about three groups: children with progressive conditions that have ongoing deterioration of their health and abilities. So these are usually rare conditions. You don't always know what is wrong with the child, but you can tell that they are deteriorating over time. They might have genetic or metabolic conditions, and you won't fully be able to diagnose them, particularly in the refugee camp setting. But that's okay. You can just recognize that this is a progressive condition of some kind and identify they need palliative care. You have some children with life-threatening conditions. So this includes most children in pediatric ICUs. They're very sick, or in neonatal ICUs. So they may need palliative care. And then many times palliative care is very important for any child with significant pain or other symptoms, because palliative care is focused on symptom management. And if we look at globally around the whole world, all the children who need end-of-life palliative care, there's a variety of conditions like you can see in this image. And I want to highlight today the two largest pieces of this circle, which are neonatal conditions and congenital anomalies. Okay, so that's where we almost have 40% of the children who need palliative care. And they're a special group. We don't see them, they don't live very long. They don't often live outside of the hospital for very long. So you may not recognize them unless you're working in the settings where they come. But we'll talk about them a bit more today. And remember, for all of our patients, we think about this framework of what can we do to help, and how do we think about what we can do to help the child and family. We think about the child's physical health, how we can make them feel as comfortable as possible, relieve their pain and other symptoms. We think about emotional issues. If the child is very young, you know, they're not going to have their own emotional issues, but we think about the family and the issues that they will have. The mother may feel very guilty if a baby is born with problems. So that's a big thing we have to focus on for neonates and very young babies when they need palliative care, is how is the mother reacting? How is the family reacting? You know, we know that most of these conditions, it has nothing to do with the maternal health. It's nothing to do with what the mother did in the pregnancy. These are either genetic conditions or they are sporadic. They're not linked to any particular action or caused by anything. We think about the social and social aspects of the family, the school friends, the community when a child is sick. We think about spiritual issues and how we can support them. This means religious things, but also means how do people make meaning? What is meaningful? They ask, why did this happen to my child? We talk about that with them because that is part of spirituality for many people. And then trajectory is very important to think about for all our patients in palliative care. How do we plan for the future? How do we plan for the likelihood that the child will die in the end of life situation? And we know that we all share responsibility for looking for children who need palliative care. So we have this pyramid, and at the top we have some specialists. And we're here to support you. You know, I have the specialist training and we have some other specialists on the call, and we're here to help you manage the patients, but we can't see all the patients. Even in the best case scenario, we don't have the option of that. So most of the palliative care is delivered by primary care, by family medicine, by general physicians, pediatricians, adult palliative care. Everyone works together, and that's why we're giving you this training, so you can know how to approach these children with a palliative care approach. And again, it's about teamwork. It's not just about physicians and nurses. We might have them involved, and often they have a role to play. They give advice. But in many situations, we have community health workers who we call palliative care assistants. We might have community volunteers. We might have speech therapists and physiotherapists and program coordinators. And these people really help bring together a web of people who support the patient and family at the center. So when you're thinking about how you make palliative care, don't just think about doctors and nurses. They need training and they need to be part of your team, but think about how are you going to bring in all these different people potentially. Now, physiotherapy and speech therapy is more relevant if you have older children who have cerebral palsy, who have genetic problems, who are going to live for longer and you need to care for them. Not so relevant for neonates. So I want to give you an example of a baby that was cared for very recently in a facility in the region of Cox's Bazar. So this baby was 650 grams and was born and was very vigorous at birth, meaning the baby was active, kind of moving, breathing, good color after a few minutes of just normal like baby care after birth. So if a baby is 650 grams, that is a baby who is estimated to be about 24 weeks of gestation, okay, 23 to 24 weeks, depending on how accurate your estimates are. And you can do more things to estimate the gestational age of the baby in terms of how you examine them once they're born. But just from that weight of 650 grams, we would expect the baby is just about 24 weeks, okay? And I say this because the single biggest determinant of what you're gonna do next is completed weeks of gestation, right? So if the baby is this small, in South Asia, the estimated survival for these babies is 0.5%, okay? It's very, very low. These babies do not have a good chance of survival because they are very complex, and to keep them alive and to have them survive long-term, meaning beyond the hospital, be able to be discharged home around the time of their, 40 weeks gestation that they would be, so after 3 or 4 months, is very, very expensive and complicated, okay? So you cannot do this outside of level 3 tertiary and ICU settings. It does not work. It is not possible. Level 3 tertiary and ICUs are very complex places. They have ventilators, they have 24-hour monitoring, you need blood work, you need to be able to get blood work very frequently to sample what's going on with these babies. And they might look good at first, but they can't keep going. They have all the complications of being premature. They are highly prone to infection, they get bleeding in their brain, they have very underdeveloped lungs, they have gastrointestinal problems, they get this necrotizing enterocolitis, they can't tolerate being fed very well, you have to be very cautious. They have congenital heart issues because their blood vessel in their heart that switches to like sort of the circulation you have after you're born doesn't always close, which is the ductus arteriosus. So all of these things, you can't manage them unless you're in a tertiary setup, okay? It's just not possible. So unfortunately, you are going to have to give palliative care to these babies, even if they look vigorous at the time that they're born, because the trajectory is that even with the best care, they will not survive this problem in your setting. Any questions about that? I think someone's maybe got a question. No, okay. So yes, you are right. Sometimes you hear about these babies being born and surviving. The babies who survive are born at tertiary hospitals, because transferring this baby to a tertiary hospital has a very high likelihood of being an event that causes the baby to get sick or damages them further, right? So we make a big differentiation between babies who are born in a tertiary hospital who have this kind of problem or this premature, and babies who are not born in a tertiary hospital, because getting them to a tertiary hospital causes them all kinds of issues. So that's where you might see that they do survive. And look, they survive a lot better in a tertiary setup. You can get them to survive, but it's not easy. It's a little bit like our kids with cancer. You know, you can read about it and find out that, yes, they could survive this cancer, but they can't survive that cancer without an intensive care setup, you know, without a transfusion system, without the ability to, you know, do really high level stuff. So all that to say is that for this baby, our care was focused on the baby's comfort. So when you focus on comfort, you're going to offer them oral, express breast milk, or breastfeeding if they would like to breastfeed. They seem vigorous. We do not recommend IV fluids or NG tubes because, again, it prolongs their life, but it doesn't give them a better chance of overall surviving. Okay. And then we do things for comfort, like give them sucrose and kangaroo care. So this baby lived for 1 week, and he looked a little bit vigorous during that week. So it was hard to understand that the baby wasn't going to survive long term, right? The baby looks strong. The baby looks like he's breathing, he's drinking milk a little bit. They gave him milk with a little syringe that they just dripped it into his mouth, and he was comfortable with that. But then on the day of life number 6, the baby started to be more sleepy, not wanting to feed as much, and his breathing slowed down and stopped. So that's a kind of common scenario, what you might see. Now, most of these babies will not live 6 or 7 days. They will not be able to live that long because their lungs are usually very underdeveloped. So what can we use to help us care for these babies when we give them palliative care? So a few things are neonatal pain assessment tools. So we have 3 tools we like to use. We can use a premature infant pain profile if the babies are premature. If they're term babies, we use the neonatal infant pain scale or another scale called CRIES. I'll show them to you. So this is the neonatal infant one. This is if the baby is term, okay, or close to term. And so each of these things here, facial expression, cry, breathing pattern, arms, legs, and state of arousal, we're going to give them a score. So for facial expression, either they get 0 points if their face looks relaxed, or 1 point if they're grimacing, meaning their face is kind of scrunched up. Okay, so similar for all these items, we score them and we get a total score. If they're premature, then the scoring is different. Okay, this is the premature infant pain profile. So we look at the baby for 15 seconds and then we give them points. So anything in this column, they get 0 points. So as an example, if the baby is less than 28 weeks, automatically they get 3 points, okay, because they're gestational age. Then we look at their level of alertness. If they're awake, active, opened eyes, and facial movements present, they get 0. If they're quiet, awake, opened eyes, no facial movements, they get 1, etc. Like that, we go across. For their maximal heart rate within the 15 seconds, we look to see how much their heart rate is increased. And their oxygen saturation, if it's available, same thing, okay? And then we observe them for 30 seconds and we look, do they have the frown forehead, the eyes squeezed, and the nasolabial furrow, which is right here, okay, between their nose and their lips. You want to see how scrunched up that is, okay? So these things you're scoring to see if you can generate a score and then how much pain they have. And again, here it says scores of 6 or lower mean the pain is minimal or absent. Scores 12 and above indicate moderate or severe pain. And this is another more basic one it's called the CRIES, Neonatal Pain Assessment Scale. And again, you look at these 5 items: crying, requires oxygen, increased vital signs, expression, and sleepless. And then you give a score. So this one should be used for term infants. Okay, premature infants, you must use this premature infant pain profile because it has a scoring piece for gestational age, which is important for premature infants. And then let's look at some basic pain treatments for these babies. So we have non-pharmacological things. Sorry, each is coming up separate. So the best non-pharmacological things are sucrose, breastfeeding, non-nutritive sucking, which means having a pacifier, positioning, kangaroo care, and a quiet, clean, dry environment where the baby's not moved around too much. Premature babies do not like to be touched and moved. They're not like term babies who need to be necessarily cuddled to be comfortable. So we'll look at each of these things. So sucrose. So sucrose has been extensively studied as a pain intervention for neonatal newborn care. There are 150 published studies relating to using the sweet taste of sucrose to enhance calming and analgesia in human infants. And how it works is that it activates endogenous opioid neurotransmitters. So your body makes substances similar to morphine itself, which we call endogenous opioids, and sucrose stimulates your body to release these, so that that's how the pain relieving effect is going. So this is how we usually use it for minor or moderately painful short procedures. And sometimes we use it in combination with other analgesics. So it depends what solution you have. Usually we have either 24 or 50% oral sucrose solution, and you give it 2 minutes before the procedure. And the analgesic effect is improved if you allow the patient to suck on a pacifier after you've given the sucrose. That's from the studies. And here's the dose that we give by the weeks of gestation. Okay, so if they're less than 28 weeks, we give 0.1 mils, and then it increases up to term or greater than 36 weeks. And then the maximum dose per day. This is a picture of a premature baby with non-nutritive sucking. So this pink is the pink pacifier that the baby's sucking on, and the baby is getting a IV placed. Okay, so again, this improves your acute procedural pain management in combination with sucrose. So we call this swaddling or facilitated tucking or positioning. So this is very effective for premature infants to relieve pain behaviors in combination with other things and just to settle them. So we know that premature infants, that they're used to being in the womb. It's very warm, it's very compressed. They like that. So that's why they calm down, their heart rates go down. We think they have less pain and they're in a better state when they're all tucked up and curled up. And you can do this with blankets. So that's why we don't leave them uncovered and just like arms and legs wide open, because they aren't as calm and they don't like it as much. And then kangaroo care, which is incredibly effective and costs no money. So it's a very good thing to do. So we know that skin to skin care with the mother diminishes pain responses for term and preterm infants, and they recover from the procedure faster. They calm down after the painful procedure, like if they have an IV or blood work or whatever, they get back to a state of calm faster if they are doing kangaroo care. And it should be maintained for 10 to 15 minutes post-procedure until the baby is totally relaxed and settled. So, and it's helpful if the mother can be sitting or lying down so that the procedure can be done and the baby's like in a position the mother can hold them. So there's an example. So kangaroo care in some of the studies about blood sampling reduces crying by 82% and facial grimacing by up to 65%. So those are some of the main things we can do, just the general measures for neonatal pain management. We still use morphine for premature babies. We reduce the dose, and I haven't gone over that in detail because it's not particularly relevant. And we can go over that in more detail for those who are caring for those premature babies. But we do still use morphine. And in summary, I just want to remind us all of our roles. So as healthcare providers, it's very important that we can be open and honest with families and help them understand their child's illness. So I think I tried to give you some information about, a baby that's this young at 650 grams, what is actually the chance of the baby surviving, and, just the practical aspects. Like, it's just, you have to explain it's not going to be possible. The baby might look viable, might look vigorous at first, but it's not something that is sustained for that baby because they have a high risk of infection, so many complications. And we also should have that integrative approach. So for when these babies are born, we integrate palliative care immediately at the time of diagnosis for them, at the time of birth. And then we should also remember about pain and symptom management for these babies. So we know that premature babies feel pain, we can assess that pain, and we can treat it, and we recommend those non-pharmacological measures for all the premature babies to help them with pain. So these are just our key points overall from today. We cannot add days to their life, we can add life to their remaining days. So we can't change how long someone will live, but we can support them, make sure that time is as good as possible. We talked about what is palliative care for children, how it's an active and total approach to care, and it looks at all the areas, physical, emotional, social, and psychological, and focuses on the best quality of life for the child and having the child and family together at the center of our care. And the types of children that qualify for palliative care, I think I've introduced you to a new type today, which is neonates and premature babies. And then of course, we've talked about before, children with other life-threatening or life-limiting conditions. There's many different ones. And how we help is by pain and symptom management. For older children, often home-based care, and then emotional, social, and spiritual support for the child and their family, which we can integrate with that whole team into the care we provide in the hospital. So I'm going to stop there. Hopefully I haven't gone too much over time. And hand over to Lila.
থ্যাংক ইউ মেগান। প্রথমে হচ্ছে মেগান যে বিষয়গুলো নিয়ে আলোচনা করলো সেই বিষয়গুলো একটু ট্রান্সলেট আমি একটু সংক্ষেপে করতে চাচ্ছি, তারপর আমি একটা কেস প্রেজেন্টেশনে চলে যাব। তো এখানে হচ্ছে মেগান যে বিষয়গুলো নিয়ে আলোচনা করলো মূলত নিউনেটাল যে প্যালিয়েটিভ কেয়ার আমরা হচ্ছে দেখে থাকি। তো এটা চিলড্রেন যে প্যালিয়েটিভ কেয়ার তার থেকে ও আর একটু হচ্ছে ভিতরে গিয়ে এটা আলোচনা করলো যে আমাদের যে নতুন একটা মডেল আছে প্যালিয়েটিভ কেয়ারের, যে ইলনেস ট্রাজেক্টরিটা আছে ডায়াগনোসিসের পরে হচ্ছে ডেথ এবং এটার ট্রিটমেন্ট পর্যন্ত মৃত্যু পরবর্তী যে সেবাটাকে দেওয়া হয়, এই বিষয়টাকে নিয়ে আলোচনা করা হলো। এবং কি এখানে একদম নিউনেটাল প্যালিয়েটিভ কেয়ার বলতেও এখানে কিছু জিনিস তুলে ধরেছে, যেমন এখানে অনেক সময় দেখা যায় যে রোগীর পরিবারের এবং কি তার যে বাবা মা থাকে তার কিছু শারীরিক, কিছু মনোসামাজিক এবং কি তার আধ্যাত্মিক কিছু বিষয় তাদের, বিশেষ করে মায়ের একটা বিষয় থাকে যে আমি আমার কেস ডিসকাশনেও এটা আমি তুলে ধরবো যে মায়ের যে একটা থাকে যে উনি খুব হয়তো বা ভয়ের মধ্যে দিয়ে যান কিংবা সবাই ওনাকে ব্লেম করতে থাকে যে ওনার কারণে হয়তো বা ওনার এই শিশুটার এই অবস্থাটা হয়েছে। তো অনেক সময় এটা দেখা যায়। মেগান হচ্ছে যে একটা কেস আমরা দেখলাম এখানে, এবং কি আমরা দেখলাম যে কয়েকটা পেন স্কেল দেখলাম আমরা যে কিভাবে আমরা শিশুদের ক্ষেত্রে আমরা হচ্ছে ব্যথাটা নির্ণয় করতে পারি কয়েকটা স্কেলের পাশাপাশি আমরা, এবং কি এখানে সুক্রোজের একটা রোল আছে যে আমরা দেখলাম যে এটা ডোজ, বিভিন্ন ডোজে কিভাবে আমরা হচ্ছে এটা দিতে পারি। ক্যাঙ্গারু মাদার কেয়ারটা সম্পর্কে আমরা জানলাম। তো এই বিষয়গুলো এখন আমি একটা হচ্ছে কেস নিয়ে আলোচনা করব। So here, this is my today's case presentation. My key questions for this case presentations are how to manage the child's pain and which sign or symptoms should alert the parents to bring the child back to hospital. And the last one is how else can palliative care help this family. So the child age is 4 years, male child, and he is a suspected acute lymphoblastic leukemia. It is not diagnosed yet, and he came with pain in our center. Some investigation we found at admission was hemoglobin was 7.3 gram per deciliter and RBC was 2.7 million per liter. WBC count was very low, 3,300 per cubic millimeter, and neutrophil count was 11%. Platelets was 1,38,000 per cubic millimeter. So the treatment he got in the department was tablet coamoxiclav. It is an antibiotic. Tablet paracetamol given during discharge, and tablet tramadol initially used to relieve pain and pain relieved after using tramadol. His pain and other symptoms was low back pain. Pain scale was 4 out of 10. It was moderate pain, and he has generalized bone pain also. He passes also sometimes red colored urine. There are some psychosocial and family concern. The family belongs to a very, very poor living condition, and the financial condition was very low, as they couldn't continue even the diagnostic test also. The 2 other children previously died due to undiagnosed disease, and as that is for that reason, patients we found patients that they are very psychologically low, and they think that this could be their fault, parents' fault, or something like that. Mother has 5 other small child to take care, and most of the time father take care of the ill child at home, and he become exhausted. The parents still hope that the child will improve if they go to the traditional healer. They already went to a traditional healer in between the 2 admission of hospital. The communication we made that after the first visit at our hospital, the family was informed about our suspicion of ALL, and we explained the nature of the disease. They were informed about the treatment of the condition, but they said further they can't bear the treatment procedure or any chemotherapy or any like diagnostic test. They could not. They have no financial issues. After also we tell them about some symptoms which can appear, and in that case visit in our hospital. The symptoms are continuous fever, bruises, bleeding tendency, bony pain, etc. The collaboration and partnership that patient as the patient was not able in the chemotherapy condition, and the communication with the patient family was collaborated with the mental health team in our hospital, and the mental health team also offered them some counseling session for the patient's parents. The summary of the case is the patient first admitted in our hospital with complaints of diarrhea and hematemesis, and gradually in the second admission they admitted with the pain, and we suspected ALL, and also telemedicine consultation done after discharge. Then after 20 days, patient again admitted with complaints of bony tenderness and high colored urine. So my key questions of this case presentation is how to manage this child's pain, which sign or symptoms should alert the parents to bring the child back to hospital, how else we can palliative care help this family.
Perfect. Thank you, Lila. That's a good case for us to discuss. So do we want to hear maybe some comments from some of our participants about what they would suggest for managing this child's pain as maybe the first idea? Because I know some of you now are more familiar with the palliative care for children, so you might have some ideas for how to manage this child's pain. And this child was seen at the MSF hospital, just so you know, in Cox's Bazar region.
Any questions?
Good evening. I have a question. I'm Dr. Zannat. Can you ask this question?
Yes, please go ahead.
Thank you. Here, three things were highlighted actually. Management for the child's pain and sign symptom management, other sign symptom management. But we have seen here initially the child has come with bleeding, hematemesis, and then most probably fever, all these things. So pain was a major symptom in that time, but hematemesis, I think, are more concerning for the family. So in this case, which will actually which will be for as a palliative management corner, which will be our first concern, either management of pain, fever, and hematemesis related problem solved, then pain, or initially pain. I just want to know actually.
That's the good points. Yeah. And obviously this patient was seen a while ago before the team had a lot of palliative care experience. So they brought this case and were asking for some advice from us. But yeah, I think that definitely the hematemesis would be, for parents, very, very scary symptom. So probably needs to be managed first and child admitted and, just stabilized a bit before being discharged home. And I think it's always challenging for us to manage patients with untreated leukemia who aren't going to get any treatment, because obviously their disease progression is different than what we're used to for children who get some treatment, which is the ones we typically see. So we don't have a facility for any type of transfusion in the Cox's Bazar region. So we're going to have to just go for some medication management of the hematemesis. So I think the child was admitted and they probably got some like pantoprazole and maybe some tranexamic acid or something just to stabilize that. But it seemed like that settled pretty quickly, because I did get referral for this case from the telemedicine program early on when the child first presented to the hospital. So that did settle after the first hospitalization. Like when they discharged the patient back to home, there wasn't more hematemesis after the treatment for that. So they used some pantoprazole, I think, and tranexamic acid. Fever, I don't know what your thoughts are, as a hematologist, oncologist, but we sort of counsel patients that they are going to have fever because the child hasn't had any treatment for their leukemia, right? So they are going to have fever, which is just disease related fever. And we aren't necessarily always giving antibiotics. I think when the child was admitted, they got antibiotics for a few days, but then when the fever settled and there wasn't any clear cause for the fever that was identified, then they discontinued the antibiotics. But if the child returns with fever, it's a balance of determining whether you would treat or not. I don't know what your thoughts are, Janet, if you have any thoughts on that, or anybody else, of course.
I completely agree with you. Thank you.
Does that have any questions for people? Because I think it's hard. It's hard to know what to do with a child who's not getting any treatment for their leukemia, but is going to be sick, right? It's a big sickness for them. So I think it's, if it's not too much to give them antibiotics, like you could give them oral antibiotics, it would be reasonable. It's probably not going to do any harm. But if they don't respond, like they still have persistent fever, then you can stop the antibiotics after 3-4 days because it's probably disease, right? Because having leukemia gives you fever. So when we say disease fever, we mean actual leukemia causes fever. So I see a good question here. Yeah, do you want to say your idea, Dr. Shohag? Want to unmute?
I think already you mentioned about I think patient already getting tramadol. Is there okay? If patient getting tramadol, can we step up during pain management?
Yeah, that's a good idea. Yeah, so we could step up the pain management. So I think maybe Lila, you can translate this idea too, but just the idea that if the patient's getting tramadol, which I know you have available, so you can use if you watch the patient closely and it's safe for children 5 and above, you could use tramadol. But if that's still the child's still having pain, because leukemia is very painful in the bones, especially if there's no leukemia treatment going on, then you can go for oral morphine if it's available. Do you want to just explain that, Lila, in a bit more detail with like pain ladder and such?
Yes, for children, we know that we skip step 2, what we used in the adult pain management, and that we don't use actually tramadol. For this patient particularly, he is 4 years old, and we got the patient, they used tramadol before. And we tried paracetamol, and the pain, we discharged the patient using paracetamol actually, and the pain was out of 2 out of 10, and patient says it is some comfortable for him. And after some days, he got admitted again. So then we actually, if there is available morphine, we use direct morphine. We don't use tramadol for child patient.
Megan has shared the 2 steps in the chat box.
Yeah, and I'm just sharing here the ladder from the WHO. Okay, so this is in 2012, the WHO guidelines for children. Okay, this is the document. It's and so mainly we use a 2-step ladder, like Lila's saying. So paracetamol and then opioids, and we prefer oral morphine. Okay, but we know that sometimes you do need to use tramadol because you don't have the morphine. So that's why, there's what you can do and what is possible and what you have available. And then, there's the guidelines. And so you have to take these 2 things together and do the best you can. And somebody, Sarpong is saying IV paracetamol. Yeah, you can use IV paracetamol, but then the patient will have to be in the hospital. So if they can take it orally, then it would be just as good to give orally. It doesn't have more analgesia IV. It's just a different route. So I know we have some participants joining from other places. We'd like to hear how you manage in your setting as well. So feel free to ask questions. If you're joining not from Rohingya camps, from Dhaka, or I know we have some participants from Sri Lanka joining. You're very much welcome, and you're welcome to ask questions that relate to your setting.
Yes, I can see Suraj logged in, and Kandipan. Siranganathan Kandipan. If you have any questions or if you'd like to share how you manage. While we wait, Megan, the other thing I wanted you to let us know, what would you do about the parents they had lost 2 other children? So they'll need some counseling on having children and what can happen, and maybe genetic analysis if possible. Thank you.
Yeah,
would
that's
you-
a good question. Yeah. So, this is their 3rd child who's going to die. It's quite a lot of children to lose in one family. So we know that every time you lose a child, like then the 2nd time or 3rd time, it's more trauma because you've already experienced this once and it makes it harder. And then we know that if it could be potentially something genetic, maybe they have a genetic condition that's leading to them having these children all have the same problem. We don't know, but we should at least do some more investigation to see if it could be determined. But then if it's a genetic thing, then the parents feel very guilty because they feel like they kind of gave it to their children. Of course, they didn't, mean to, but we have to talk to them about that and just help them understand that, these things happen and it's not anything that you did wrong. So someone is saying in the chat, is it good to go for genetic analysis? Is patient very poor? So you have to assess. Okay, so you have to take a history more and determine why did the other 2 children die? Okay, did they just have like diarrhea or pneumonia or something normal? In which case you may not go for further.
Maybe consanguinity, because among Muslims in Rohingya community, it may happen. Right?
Yeah, consanguinity.
Yes.
Yeah.
Sorry, ma'am, I missed the point. Sorry.
Consanguinity, marriages between cousins, within the family. So sometimes you get genetic some anomalies.
Exactly.
Yes.
Actually, from my experience, what I have witnessed is that this is very common for the marriage between the relatives, I mean the nearest relatives. And the child marriage is a common phenomenon inside the Rohingya community. So it's happened. It's happened quite regularly. So in that case, as a result, I didn't get this kind of a disease, this kind of reference I can't mention actually. Yeah.
Yeah, and it's different than in the regular host population, right? Because the Rohingya population, if the other 2 children died in Myanmar, like nobody was vaccinated. So they would be, there's much higher rates of childhood infectious diseases that we don't see in Bangladesh because people are vaccinated against those diseases, right? So you may have had children in Myanmar who died of very common illnesses that we no longer see in Bangladesh very much, right? Like neonatal tetanus and just pneumonia, diarrhea. Like they had a lot less access to medical care in Myanmar. So you may expect higher rates of child mortality. And to be honest, leukemia in children is rarely an inherited genetic cause, right? Janet can probably say more, but there's not, the most common genetic condition that's associated with leukemia is Down syndrome, trisomy 21. Which is very obvious, right? Like you're going to know if the child has trisomy 21. So, and there are other rare genetic conditions where there would be, an increased chance of inheriting or, having leukemia, but it's not very common in children. So most likely situation in the family is 2 children die of normal childhood diseases, most common things being pneumonia and diarrhea, and then sporadically they have a child with leukemia because leukemia is the most common childhood malignancy, right? So it can come.
Thank you. I think someone is saying if an NGO can support or social welfare support could be arranged for the family for counseling. Yes, it's been mentioned already. Thank you. Any other
Yeah.
questions?
I see a good point here. Shokiba is making, just keeping an eye out for the other children, right? They have 4 other children who, sometimes if one child is sick, the other children get neglected because the parents are focused on the ill child. And so making sure that the children who are not sick with leukemia have enough food, have somebody looking after them, have proper care, because they're the children who are going to survive. So they also need to be cared for. So often we do counsel the family about making sure you look after all your children. Do they have enough support? Who can help them look after the other children? And that could be through an NGO or social welfare to make sure they're getting enough food for the other children. And because often they're spending a lot of money on the sick child who's in the hospital. But we want to emphasize, make sure the other children still go to school and make sure they're well fed, because they're actually the ones who have the longest life ahead of them. So we want to maximize their potential. In terms of counseling, maybe I'll say a little bit more about how we could counsel these parents, because you're going to feel like you don't know what to say, right? It's very sad. You can't make it any better. Nothing you can do is going to change the situation, really. You can make the symptoms better, but you can't change that the child's going to die. And that's really sad. So I think the thing that parents find the most helpful for us to say is just to be with them and just to listen to them and just to show that we care, and you see a lot of people who are sick, you see a lot of people who die, but just to say, this is really sad. I'm really sorry that you have to go through this. This must be really difficult for you. I'm praying for you. And they find it helpful if we call them, so sometimes it helps to just give a call after the child has died, usually 1 month afterwards. We just call them and say, how are you doing? I was thinking about you. How do you feel? And it's not that you make it any different, but you just kind of just share a little bit, because you know what they went through. So you can be a bit of a support in that way. But you don't have to fix anything. I think one thing that we know and we learned is that it doesn't help if we say, don't worry, right? It doesn't make people worry less, right? We remember that from our counseling session. If you tell the parents, oh, don't worry, it's going to be okay, that doesn't help people feel better. So you don't need to say that. I don't know, Lila or Rumana, or anybody else, does anyone have any suggestions of things they say in Bangla when they're talking to families who have a seriously ill child or bereaved child?
It's I think just to add 2-3 things along with what you've mentioned already. We can counsel, as Megan has suggested. Listening is very important. Being with them is important. Also, we can let them know that if they want to ask anything, they can come back to you or someone and share their worries again. And if they need separate time, you can also make time and suggest that they come and sit with you and, have a special time for them, and where they can share all their worries, and maybe they'll just sit and cry with you around them. That's also fine. I think that sort of support is important. And maybe if there are other parents who have had such condition later on, some sort of group can be created if many such patients are there in your center, so they can share each other's pain and understand what to do. And sometimes marriages are in a serious situation when a child is ill, so parents separately, husband wife, need counseling, and no one should be blaming anybody, because no one does this. If it's a genetic condition, no one really passes these on knowingly. It can happen to any of us. So we have to counsel so there is no such misunderstanding. Thank you.
Thank you. And someone mentioned about counseling the children in the chat as well. So the siblings, the brothers and
Other
sisters,
siblings, absolutely.
that they know what's happening. Because the same thing happens for the children, the other children in the family, right? If the parents say, oh, don't worry, he's going to get better, it doesn't help the children worry less. They worry because they see the parents worrying, right? The children, how they react is going to be a mirror of how the parents are reacting. So we sit with the children, we explain to them if they're old enough, he's sick, we're giving medicine so he feels okay, but he's very sick, if they're old enough, we explain he's not going to get better, he's going to get sicker. You kind of go based on how the children, how old they are and how they react, but we do explain because something that's not true, help people feel better when you lie to them, right? They feel worse because then they feel angry at you, or they don't trust you because you didn't tell them something that was true. So.
Absolutely. And maybe at some point, if it's relevant, then schools need to be informed as well. Teachers, if the children are going to the school, to support the siblings. So,
Yeah, that's a really good point too. Yeah.
আর কারো কোনো প্রশ্ন আছে? Do we need to translate this in Bangla? So,
maybe a bit of a summary is good always.
Yeah. So আমরা এখানে বললাম যে যদি কয়েকজন বাচ্চার একই অসুখ হয় বা যে মা বাবা অনেক বাচ্চা হারিয়েছেন, 4 জনের মধ্যে 3 জন হারিয়েছেন, এমন যদি হয়, তখন তাদেরকে আমরা যেন বুঝাতে চেষ্টা করি যে তাদের বাচ্চাদের এই সমস্যা হতে পারে, যেটা জেনেটিক হতে পারে, অন্য কোনো কারণে হতে পারে। আমরা তাদেরকে কাউন্সেল করব, কিন্তু এমন ভাবে না যাতে একজন আরেকজনকে আবার ব্লেম না করে, মানে দোষারোপ না করে বাবা মাকে বা মা বাবাকে, অথবা শ্বশুর বাড়ি অন্য তাদের একজন আরেকজনকে কোনো দ্বিধাদ্বন্দ্বে না ফেলে দেয়। এইভাবে সুন্দর করে বুঝাতে হবে এবং সময় দিয়ে আলাদা করে তাদেরকে নিয়ে বসতে হবে। আর যদি সম্ভব হয়, যদি সেটা টাকা পয়সার সমস্যা না হয় বা ফ্রি করা যায় বা কম খরচে করা যায়, একটা ক্যারিওটাইপিং বা জেনেটিক অ্যানালিসিস আমরা করতে পারি। আর যে বাচ্চারা বেঁচে আছে, তার যে অন্যান্য ভাই বোনরা মারা যাচ্ছে, তাকেও কিন্তু জিজ্ঞেস করতে হবে যে তার মনে কোনো ভয় আছে কিনা, কোনো চিন্তা ভাবনা আছে কিনা এবং কি হচ্ছে, কারণ তারা দেখতে পাচ্ছে, হয়তো কোনো উত্তর খুঁজে পায় না। আর মা বাবার মধ্যে এত কষ্ট থাকে যে তারা হয়তো এটার সময় করে বলতে পারে না তাদের বাচ্চাদেরকে। আমাদের সেটা দেখতে হবে। আর যেখানে প্রযোজ্য সেখানে স্কুলকে আমাদের জানিয়ে দিতে হবে যে এই বাচ্চার ভাই বোন বা কেউ মারা গেছে, আগেও মারা গেছে, এর মনের মধ্যে অনেক রকম প্রশ্ন আসতে পারে। টিচার যেন সাপোর্ট দেয় এবং এটা মনে রাখে। থ্যাংক ইউ ভেরি মাচ। ধন্যবাদ। আপনাদের আর প্রশ্ন থাকলে বলবেন।
Any other comments, especially from any of our pediatric in people on the call? Very welcome. Any questions or comments? Okay, so maybe I'll make an announcement about the upcoming course. So there's an upcoming pediatric palliative care course that will start on October 8th. We'll share in the WhatsApp group, and this will be 6 weeks on pediatric palliative care. This is an international course, so it's going to be all in English, okay? But anyone is welcome to join. And we'll be welcoming participants from all across, mostly South Asia is our target. So if you're interested and you want to focus on pediatric palliative care, please join us for that course. And we will continue our mentoring sessions for the Rohingya refugee ECHO program. So the next one will be in 3 weeks. And we don't have a topic yet. We'll get back to you with the topic. And I see Saeed has some announcements to make.
Megan, the link
And I
you
just
shared.
add something, Said. Megan, Burdham Hospital doctors who are working at this NICU, Special Care Baby Unit, neonatal, I'd like to request them to register. So do we have space? So
Yeah, we have space. We still have space.
Okay.
So I'll post the link and the poster in the WhatsApp groups.
great.
Um,
I'll share.
yeah, that'd be great.
Thank you.
Okay, Dr. Megan, my query is the link you shared earlier. I found this one is not working.
Yeah, that's a Bangladesh thing. Just copy and paste it into your browser and it will work.
Yeah, I tried already. Yeah, it was not working. Yeah.
Still not working. I don't know.
If they are, okay. I think the URL is
it's
shortened.
really-
I think the URL is
yeah,
shortened.
it's a shortened URL.
Okay. Okay. Could you please share the real one?
Yeah, okay.
Yeah,
We'll
sure.
do that.
Okay.
That course is a different course. So Saeed is mentioning another, it's less of a course, but a series of webinars on various topics in pediatric palliative care, which starts on September 16th. And there'll be one session every week from ICPCN for a number of sessions. So that one, I'm posting the link here in the chat. Hopefully this is the right link. And that one you can join as well. But if you want to join our course, that will be 6 weeks and then you'll get a certificate for the course. It's the same course that we ran in Bangla in July. Okay, so if you took the course in Bangla, it was like Bangla and English in July and August. It's the same course. So you don't need to join again. It'll be maybe a little boring, but you can join those webinar series. It'll be quite interesting. Yes, we'll see you at the course and the webinars. So if you don't have the information and you don't receive it via WhatsApp or by email, please just email Saeed or myself and we'll be happy to share it with you if you haven't received it in one of the other ways. Okay, thank you everyone. Have a good evening. Balataken. Thank you, Ramana. Thank you, Laila.
Thank you so much for this excellent session. Really enjoyed listening. Thank you, Megan.
Thank you.
Megan and Lal.